A hospital saved your life. It also gave you something you cannot name. Now you plan your route so you don't drive past the hospital. You change the subject when it comes up. You cancel the appointment you know you need. That has a name: medical trauma. Welcome to the Biology of Trauma podcast. I am your host, Dr. Aimie. My guest is Dr. James Jackson, a neuropsychologist at Vanderbilt, who co-founded one of the first clinics in the country for survivors of critical illness. He wrote the book, Reclaiming Your Life from Medical Trauma. And here is what sets us apart from every other kind of trauma we cover on this podcast. The source of it lives inside your body, and you carry it without even knowing that there was a thing called medical trauma. And so in this episode, you will hear the one sign that Dr. Jackson watches for above all others and the single instruction he gives every patient. This is part 1 of 2 episodes, so stay with me to the end because that sign is one of the 5 patterns of stored trauma. I will show you how to find out in 2 minutes which one your body runs when life becomes too much. Because we cannot change a pattern we cannot see, so I want to share that assessment with you. And with that, let's jump in. Dr. Jackson, medical trauma sits close for me as a physician. I have watched what people carry home from a hospital visit or a surgery. Why did this become your work?
Medical trauma is a topic that is hugely resonant because so many people have had some degree of medical trauma. We can parse definitions, we can be broad or we can be narrow in how we define it. I'm not that worried about precise definitions. I feel a bit like that's like arguing over how many angels fit on the head of a pin. It's not hugely productive to define the outer boundaries of medical trauma. To me, what I think is helpful is to affirm people who are experiencing it and to say, this is a problem. This is a gigantic problem. And if you have been in the ICU, if you have been on the heels of a difficult surgery, if you have had a emergency C-section or a huge panoply of other difficulties, you very likely have endured medical trauma. And the message to people who have endured medical trauma is we want to affirm you. We want to meet you where you're at. We want to give you language to describe the difficulties you're having, because far too often in this relatively enlightened age that we live in, people continue to have very narrow notions of trauma, which involve things like combat and abuse or assault. And to be sure, those are traumas. No one would dispute it. We're not comparing traumas, but those are not the only sorts of traumas. And traumas in this medical arena writ large are absolutely traumas. So that's why I'm doing this work, to try to assist people who are in the throes of medical trauma, whose lives are often derailed by medical trauma, whose lives need to be reclaimed because things often are not going too well for people with medical trauma.
Well, and as I look at what you've done with your work and your life, you're a man after my own heart, where we don't just study it, we then do something about it. And you co-founded the ICU Recovery Center, one of the first comprehensive clinics devoted to those who have had critical illness and helping them get their lives back. But I want to know, what was the reason? What was the moment when you realized this is what people need? What were you seeing that led you to that decision?
It's a really interesting question. I'm writing a grant. It's about the challenges of people in rural America to get the mental health care in particular they need. The reason I mention this is that when I first came to Vanderbilt, quarter of a century ago, one of the key things I did in the early days of our research was I talked to ICU survivors about what had happened in their life after they left the ICU. At that time, people were very focused on survival. Physicians were very focused on survival as really the only outcome of interest. If you survived a life-threatening illness, that was great. But patients increasingly were saying to me and to other people, frankly, we care about a lot more than survival, right? Like if I've survived the ICU, but now I'm demented, if I now have profound PTSD, if there are all sorts of pathologies that I have, what has happened exactly? What have you done? And the stories that I heard, they were really arresting, and they were stories of trauma. They were stories of people being fine on a Monday and developing a problem very rapidly, often an infection or a pulmonary condition or whatever, but very rapidly develop this problem. On a Monday, they're fine. On a Wednesday, they're on a respirator, fighting for their lives and feeling incredibly disoriented. The situation's almost surreal. And then they get thrown out, literally sometimes don't even go to rehab. And all these experiences left a mark. And when I heard about this trauma one time and two times, three or four times, it could seem like a series of one-off events. But over time, after interacting with hundreds of people, they had the same story, same narrative arc. I was this way, then this happened. Now I'm disabled or derailed. I thought, we're really onto something here. This is a problem. And what do you do when you learn of a problem? You roll your sleeves up and you jump into the deep end and you try to help. That's always been my impulse. And in the early days, we didn't have a lot of knowledge about this condition that is now known as post-intensive care syndrome. And Carla Sieben, my partner in the ICU, and we literally did jump in the deep end. We said, let's start a clinic. How do you start a clinic? I don't know. We haven't done it before. Well, you know what? Let's do it, right? Like there's never a good time to get pregnant. There's never a good time to get married. So it goes, right? There's never a good time to start a clinic, but there's a need. So we tried to meet it. And it was a little bit like the Field of Dreams analogy, which is if you build it, they will come. And people started coming from all over the United States. I'm not sure we've had people from other countries. We've had people want to come, but from all over the U.S. And the defining feature, I would say, of their stories has been this hard to explain for them, hard to understand trauma that casts a long shadow and results in mental health problems, cognitive impairment, physical debility, loss of work. It's life-changing. And it's been a privilege to do this work, as I know your work is viewed by you as a privilege, to try to help the vulnerable people among us, because they often don't have a voice. And if they had a voice before, trauma has often robbed them of that voice, and they need all the help they can get.
I love that you've really pioneered post-intensive care syndrome. And yet, I don't think that this is still being spoken about in mainstream medicine by our colleagues. Have you seen that start to shift, or are you still feeling like you're shouting in the dark when it comes to your colleagues and recognizing that there is a post-intensive care syndrome?
Yeah, it's a great question. I would say awareness of this is developing. To me, at times, it has felt like it's developing at a glacial pace. But if you look objectively, many more people are aware of it than used to be. It used to be the case that I would speak at a meeting about this topic, or perhaps I would be an expert witness in a legal case and I would talk about this topic, whatever the case. And it would go over people's heads. It would fall on deaf ears. People would have no awareness of it, sometimes push back against it. Due to the fact that we've now published dozens of papers and others have, and patients have begun to take on quite an advocacy stance. There's something called the Walk for PICS, for instance, that takes place in late September every year. And last year, I think we had 30 or 40 sites. We had 1,000 people plus around the world. They were walking for PICS. So the awareness has grown, but it's been really slow. And it's unfortunate when you talk to survivors of the ICU with PICS, the key thing they will say is, hey, I went to my doctor at a small clinic or big medical center or whatever, and I raised my hand and I said, I'm having a hard time. I've learned this problem has a name. It's called PICS. They'll tell you that far too often there's a little bit of an eye roll or a little bit of disinterest, or sometimes a much more compassionate stance, but still, I'm sorry, we don't know what that is exactly. And I think part of our challenge, as you know, is to educate people. And when you think of post-intensive care syndrome, which refers to the idea that you've got brand new problems with your brain or with your body, with your mental health, it only makes sense that this is a real phenomenon, because when you look at the dynamics of critical care, and we're better, and I'm glad we are, at keeping people alive for a longer amount of time so we can try to heal them, right, to get them out the door. People are able to endure things they couldn't before. So glad that we're offering better support to people than we were. It's all evidence-based is good. But, if I put you on a ventilator or you put me on one for 40 or 50 days, if you sedate me heavily, if you immobilize me, and that culture is changing. I mean, we're promoting mobility, but if I'm laying in a bed, if I'm wildly delirious, how could those things not cause meaningful and pervasive and often permanent problems? Of course they're going to, right? There's no way around it. When I was a kid, I'm dating myself. This will be a quick story. I loved to fish, and there was a company, Shakespeare. They made these fishing rods. I loved them. We didn't have a lot of resources, and my dad won a very special fishing pole for me in a sales contest. It was called an ugly stick. It was a brand new kind of fishing pole, very bendy. There was an ad with Hulk Hogan in some fishing magazine, and he was bending the ugly stick like this. He was bending the rod like this, if you can picture it. And so I was probably 11 or so, and I thought, I'm going to do that. I'm going to bend this ugly stick. It's amazing. It's so flexible. I can catch fish. So I took it outside. I bent it like this. Unfortunately, it broke, right? It broke. My ugly stick broke. We couldn't afford a new one. It was really disappointing. But the lesson is, if you bend something enough, it's going to break, right? And as it relates to trauma, if we load people up with enough trauma, we haven't talked about this, but I imagine you agree. If you burden people with enough trauma, they're going to break. I mean, that is going to happen, right? Send people on 14 deployments. They're not designed for that, right? Give people 19 consecutive surgeries. It's too much. And so the onus on us is twofold, I think. One, how can we heal people, help people heal after the trauma? Two, how can we try to, if not prevent it, mitigate it at least a little bit, because we're human, right? If you poke me, I'm going to bleed, and we are not designed to handle an infinite load of trauma. But people in the ICU often do.
Absolutely. So I'm thinking of people who have had an experience where they've either been through a surgery or been in the ICU or some combination of both, and they've never heard of PICS. They've never heard that you can have post-intensive care syndrome. They are starting to try to get their life back, and they're only focused on their physical health recovery because that's where the emphasis has been, and they've been discharged home because they're good. They're fine. They can recover the rest of the way from home. How would a person know? What are the things that start to appear that a person would even be able to say, oh, I think that mentally, emotionally, my body is having a hard time recovering from that amount of traumatic stress that it was under? Is there some type of, like, it usually starts this way, it usually looks like this, and then it builds into this?
Yeah.
What do you tell people? What do you see?
Yeah, well, it's a great question. I mean, often the symptoms that we see often the difficulties we see are a little bit slow to emerge. And the reason they appear to be slow to emerge is when people return home from the ICU, they're quite slow in trying to re-engage their life, right? They're pretty debilitated. So often they're pretty isolated. They haven't done much around the house. They're pretty withdrawn. And it is as they start driving, for instance, they notice, wow, I just ran that red light. That's really weird. I'm not paying attention. Or they return to work and they notice, I'm having a hard time with these spreadsheets, or I'm not integrating information quite rightly. It's a processing speed problem is what I would call it. They might not have that term. So it is as they begin to integrate that they see these problems emerge, and I'll land on the emotional problems in particular because these have, I think, a little bit more of a signature, and the signature that we see in medical PTSD at least is a signature that's really driven by avoidance. We see really prominent avoidance, and in the parlance of classic PTSD, Vietnam veteran driven PTSD, you used to hear when I talked to a lot of Vietnam veterans, you used to hear them say things like, I went to Washington, D.C., but I would never go to the wall, right? That was too traumatic. Or, I could watch comedies, but I'll never watch, a movie about Rambo. I don't want to watch Black Hawk Down. You would hear them say, I can't be around a crowd, right? Like classic avoidance. Now, for people enduring medical PTSD, they have no problem watching war movies, right? That's not the issue. But they don't want to watch The Pit. They very much don't want to watch The Pit. They don't want to visit a loved one in the hospital. They generally don't want to go to the hospital. I met with someone just the other day who said, I don't even want to drive by the hospital where I was in the ICU. And so I plan my day. It's very inconvenient because it's on the way to work to make sure that I avoid driving by the hospital. And frequently, and this has been studied, they have a greater than normal number of hospital visits that they cancel, doctor's visits that they cancel. If they have symptoms like chest pain, they're very reluctant to go to the ER, even if they should. They really are avoiding anything that would remind them of what happened at the scene of the crime, as it were, even if that's the place that saved their life. The avoidance is the symptom we see. That's the one we worry about because, as you know, if you avoid things long enough, before long, you can't really avoid them anymore, right? Because the problems will catch up to you. So the thing I worry about the most is what I would call medical avoidance.
The implications of that are far-reaching, and they are not going to seek out the help when they need it for the next condition or symptom that develops.
Yeah, that's right. I mean, many years ago, and I'll talk quickly about avoidance here. My wife and I had moved to Nashville. This was in 2000, and we had a little car. We'd driven it from California. It was a Mazda 323. It was a hatchback. And one day the check engine light came on. I was really busy with work. We had a baby on the way. And I thought, I don't have time to take this to the mechanic, but it's bothering me. This check engine light is bothering me. So I had a Post-it note in the car. This is a true story. I covered the check engine light and I thought, you know what? This is fine. I'm not noticing this anymore. And I just kept driving. And about 6 months later, late one night, West Nashville, the car starts shaking and then it starts smoking and it died by the side of the road. Right. And that next day, I sold it to a shop that bought metal and other such things. I sold it for $50 the next day. The engine died. And that was my avoidance story, right? And I think few of us might do that. I did that. But many people, in ways obvious and subtle, will avoid leaning in to hard, provoking things that are going to activate their trauma. And I use the word lean in all the time. I use it so often because the antidote to so much of this, just to be clear, it's not simple, right? It's not simple. But the antidote is lean in, right? Like lean into these really frightening things. If you do, they will briefly appear even more frightening. But if you don't retreat, they will quickly appear less frightening, right? And that's crucial. Lean in, because if you give anxiety a little ground, before you know it, it is setting up shop in your life. And you're actually not doing much of anything because you've given it an inch, it's taken a mile. And that worries me a lot. The guidance I give patients is not elegant, it's simple. Lean in, right? Surround yourself with supportive people who can care for you. Find providers that care deeply for you, that will nudge you but support you, and lean into hard things, and your life will transform.
Yeah, I talk about the 5D patterns of how to recognize when trauma's gotten stored into your nervous system, and its disconnection is the first one. This idea that it's actually hard to be present, it's easier to avoid.
Exactly.
So the solution does actually sound simple. Lean in. Okay. It's just not easy.
It's not easy. It
It
is
is
not
not
easy.
easy.
Yeah, it's not easy. And I would never want to suggest that it's easy. And I would also not want to suggest that it is quick, right? The solution is not quick. And, when I think about surviving the ICU and coping with medical trauma, um, I have a very expansive view of how long that takes. And often recovery, whatever that looks like, and that can look different for different people, but recovery to me, it can take years, right? It can take years. And I think that perspective is actually really helpful. So often, Aimie, I have interacted with people who have said to me in a clinical context, I was in therapy before, that didn't work. Sometimes emphatically they say it. Yeah, it's so stupid, it didn't work. And I will say, well, how long did you go? And they sometimes will say, well, I went 3 or 4 times. I went 5 times. And I won't say this to them, but I will think, of course, well, that's why it didn't work, right? Like add a couple zeros onto the end of the 5, right? And for me, this is very personal, not to get too personal, but in, excuse me, in 2018, I was diagnosed with OCD. I developed kind of late in life OCD, kind of out of the blue during a stressful season. And it was terrifying for me, and it created a lot of challenges for me. So I went to see a psychologist, and I said, let's just get rid of this thing. Like, I don't really like this. Let's just get rid of it. And she said, kindly, but, firmly, I don't think we're just getting rid of it, right? Like, I don't, yes, we can work on it. Maybe, I don't think, though, you're just getting rid of it. And I said arrogantly, well, I get rid of things. Like, I don't, other people accept things. Like, I get rid of things. And I think she thought, well, we'll see about that. Well, anyway, hundreds and hundreds and hundreds, probably not hundreds and hundreds, but you get the point. Many, many sessions later, I had made profound progress working with her. And the OCD is well managed, and I'm really thriving. But it took years, right? And I think we need to set the frame with our trauma survivors, which is, yes, you can get better. Lord willing, you can get a lot better. And it's going to take a very long time, perhaps. So the more you can calibrate your expectations, the better. Are there people who do EMDR and they have a dramatic transformation immediately? There are. Is that the experience of most people? I don't think it is. It can happen, but sometimes this is a long journey. And the message that I communicate is, and that's okay, right? Like, while your trauma's here, yes, let's try to treat it. But importantly, let's make space for it. Let's find a way to help you treat it like an unwanted house guest, meaning, you know what, I don't love it that this stranger has set up shop in my house, right? I don't love it. Bothers me, right? My cousin's third cousin or whoever, he's kind of obnoxious, but he's living with me now. I'm going to make space for it. That's what I think we need to do with trauma. We need to learn to make space for it, even though we don't like it, while we're working on it.
Avoidance. That is the sign that Dr. Jackson watches for above all others. And I want to name what it is in the biology of trauma language before we go. In the biology of trauma lens, we call that the pattern of disconnection. And it is one of the 5 patterns that our body uses to hold on to its protective patterns when we have stored trauma. Those 5 patterns are disconnection, disruption, depletion, dysregulation, and disease. I built a free assessment that takes about 2 minutes and names which of the 5 is loudest in your life right now. It can be found at biologyoftrauma.com/quiz, and the link is in your show notes. And on part 2, we picked this conversation up. Jim redefines recovery in a way that may change what you are aiming for.
But if the trauma happened in your body, you're carrying that around, right? You're carrying it around, and you can't avoid it. It's always there. And I think in some ways, that is why medical trauma is uniquely challenging, because you're carrying around the source of the trauma. Too often, the way that I think we have primed our patients to define recovery is, you know what, you're not recovered until we take an eraser out and erase all these symptoms. Well, you know, respectfully, good luck with that. If you join arms with people who love you, who you love, find them wherever you want to find them. It's going to be much better. Don't go it alone. Whatever else you do, don't go it alone. Find your people.
I also tell him something about my 4 years of general surgery residency that I rarely share with the public. I was the one they handed the saw to. Part 2 comes out soon. If you follow the podcast, it will find you. Until then, here is your one thing to do today. Name one thing you have been avoiding. Naming it is the task, and moving toward it can wait. Just the naming of it. That is the one thing that will give you a better tomorrow. I'm your host, Dr. Aimie. Until next episode, lots of love.